Professor Sikora has been a clinical oncologist, to my knowledge, for about 50 years. And he is currently a professor of cancer medicine. I think it's at Buckingham University. But most importantly, he has written a book, drawing on his own vast experience of many years, designed to help us as patients to take control of our issues and to learn to manage our doctors instead of always being managed by the health system. And I think that is such an important message that I'm really delighted that we have that as the focus of this meeting. So Karol, I'd like to hand over to you.
So my name's Karol Sikora. I'm sitting in my garden, having been stuck on the traffic on the M40 for the last 2 hours. But anyway, here I am in time because I didn't want to let Louise down. So I'm an oncologist, and what do I know about thyroid disease? I only learned about it when I was a student, and I forgot about it when I was a registrar. But the lessons from cancer are very similar to any complex disease. So I've looked at what you do as a trust, and basically you're supporting thyroid patients with the whole spectrum of benign and malignant thyroid disease, the realm of endocrinology, hormone treatments, either up too high, too low, or variation. So what I'd like to do, I have written a book. I'm not going to plug the book. I just want to say that there are certain things that are common in every healthcare system. It's not just the NHS, it's not just Britain, every healthcare system. And the one thing you note is that informed patients about their own illness do better than those that are not informed. It's a bit of a puzzle why that should be, especially with a system like the NHS. Surely everyone's getting it free, there's no cost to the individual, but some patients seem to get better quality care than others by international standards. And on the whole, it's those patients that are informed about their disease. And patient experts are now very, very common. You know, when computers came, when Dr. Google first hit the scene and people were looking things up, I must have been about 35 then. I just got the chair at Hammersmith, and I remember the first patient coming in with a publication and about their breast cancer, and I didn't know, and they asked me a question from the publication and I didn't know the answer. So rather than say, let me see it, let me go onto Google and find it, I went out to the nurses' station where the chemotherapy, the blood counts come in, and typed onto Google on the computer outside, away from their site, then came back in and said, yes, I understand what you want. So I was ashamed to show that I didn't know something they knew. And that was the old way of doing medicine. The doctors knew everything, the nurses knew everything. It wasn't a level playing field in terms of information. Patients had nothing. The healthcare system had it all. And the healthcare system is not just your medical attendants, whether it's doctors, nurses, physios, radiographers, and so on. It's a system. And understanding how the system works and how the systems in all economies of health are essentially rationed really helps. So the thing I'd like to talk about is, where's the future of healthcare going? How does it look like? And the way I like to explain it is there's really 4 boxes to open about the future. And the first box is the easiest box, and that's the technology box. So in cancer, it's all about better scans, better imaging. I remember when I was a young registrar seeing my first CT scan. The year was 1974, and suddenly there was a CT scan. I'd never seen one before. It was actually pioneered in the UK in Wimbledon, at the Atkinson Morley Hospital, but quickly transferred to North America, and the Americans made an awful lot of money about building CT scans with essentially British technology. So what the CT scan did was show the internal anatomy of the body, the structure, which in cancer is really important. You can see the cancer, you can see the surrounding normal tissue, you can see the routes of drainage of the normal tissue, so you can see where the cancer was likely to spread in a way that we'd never imagined before. So that was really a step change a technology step change that suddenly changed the whole diagnosis of cancer. It changed thyroid disease. If someone has a lump in the thyroid, the first thing you do is an ultrasound. The ultrasounds we had back then were very primitive. Now you get a lot of information from a relatively cheap and very rapid, obviously non-invasive technology. There's no needles involved. You put the ultrasound probe over the neck and you get an image of the thyroid gland, and you can sort out things. Thyroid disease has amazing technology because we can follow radioactive iodine in patients. We can see where it's going. We can see if thyroid hormones are being overproduced, underproduced. And we can look at the links between the thyroid gland and the pituitary, which is the conductor of the endocrine orchestra, it's often called, which sends signals, thyroid stimulating hormone to produce thyroid hormones. And an abnormality, any pathway, part of that signaling pathway, right from the brain, from the front of the brain, the hypothalamus, through the pituitary to the thyroid, causes problems. And lots of things can affect that, including autoimmune disorders. But going back to the future, the technology is important, both for diagnosis and for treatment. And, you know, in cancer, there have been huge advances in surgery, without actually making scars, there's a dog barking, sorry about that. I shouldn't be in the garden really. Keyhole surgery, so there's very little scarring, and then orificial surgery, where you're going through either down the esophagus inside to the abdomen, or through the rectum inside to the abdomen. These are technologies that are really revolutionizing not just cancer, but the whole of surgery. Having an appendectomy, when I was a young house surgeon, I used to have to do appendectomies in Addenbrooke's Hospital, Cambridge. And I was clumsy, and the patient had scars, and they were in hospital for 4 or 5 days. Now, people are in overnight, they go home the next day with keyhole surgery for most patients. Not everybody can help. Radiotherapy, amazing. The advances in radiotherapy are all due to better imaging. We can see where the radiation is going, computerization, and so on. And then, of course, chemotherapy and designing protocols for an individual patient. We call it personalized medicine. The Americans call it stratified medicine, but it's the same thing. The idea that Mrs. Jones and Mrs. Jones and Mrs. Smith may both have breast cancer that looks exactly the same down the microscope, but in reality, they have very different pathways on how the cancer arose. And identifying those pathways helps to decide the optimal therapy for Mrs. Smith or the optimal therapy for Mrs. Jones, which may not be the same thing, even though they have the same type of cancer. So all those technologies are part of the future, and they're ongoing. And then, of course, the biggest buzz at the moment is artificial intelligence. Can it replace doctors? Can it replace lawyers? You know, I heard about ChatGPT. I don't know how many of you have heard of ChatGPT. It's an artificial intelligence program. You can get it just by looking ChatGPT on Google. And if you play with it, it's quite fascinating. And as doctors, every year we have to do our appraisal. I'm doing mine on Friday evening. And you have to show that you've been on court 50 hours of continuous professional development courses, but you have to reflect on them. And I hate reflecting. Doctors of my age don't reflect well. We go to a course, you listen, you make notes, you learn, and then that's it. And someone says, well, write 500 words of reflection. So I struggle to do that. So this time I got ChatGPT to write it. It's done it very nicely. I haven't told the appraiser yet. I have to tell him, as long as he passes me, I think he will, because it is very good. And the robot, of course, starts by saying he or she, it doesn't say which gender they are, has no emotion and cannot add emotional overtones to the analysis of reflection, which is fine. And then it tells me how wonderful diversity in healthcare is and the course would be and so on. It's just the sort of stuff you write. I don't think many people read it anyway, so it doesn't really matter. But seriously, the power of artificial intelligence in medicine is greater than doctors' ability to analyze the totality of data. And if you take something like thyroid disease, which when you're a medical student seems very simple, you know, it's either thyroid hormone is either up or down, and then you learn the set of symptoms that thyrotoxicosis when it's up or myxedema when it's down causes, and you know, you're trained to actually recognize patients that have either of those by the signs they develop, you know, and but there are lots of subtleties. And what the computer can do is take all the information, all the blood data, all the electrolyte data, liver function, and look for connections that the human eye wouldn't see. And that's why one of the most interesting artificial intelligence programs used in 3 London hospitals at the moment are predicting patients that are going to go into shock meaning blood pressure drop and at risk from cardiac arrest in the hospital. Because obviously, if you can predict who's going to have it before it happens, you can actually treat it so it doesn't actually happen. And the programs are now available to monitor a whole spread of data. And that's what artificial intelligence is really good at, looking at a whole set of information too big for the human brain to deal with. So that's the technology box, and it's going forward. It's going forward for everything, for cancer, and I've seen huge changes during my professional career, but also for thyroid disease. You know, the measurements we can get now, the precision of it, and the titration of the. If you take myxedema, where you're low in thyroid, thyroxine, making sure the dose you're giving to an individual patient to replace natural thyroid hormone is not too much and not too little. Getting that exact level is really important. And so technology can help there. So that's one box of the future, and that's going to go on forever. It's driven, it seems to get faster and faster as we get older. That's it just seems that we're going through exponential rate of change of technology. And it's the same in everything. It's the same with the mobile phone, the same with your home computer. Any gadget now, you know, there's an app to go with it, and it's a nightmare for people of my generation. But younger people are a bit better. I get my kids to help me with things now and again around the house with apps that you need to. The fridge comes with some sort of app. Or one of the gadgets we've got has an app you put on your phone. I mean, what a frightening world. The second thing in the second box is delivery. How do we deliver healthcare? And one of the big crises in the NHS at the moment is, you know, you just can't access it easily. You know, in the old days, when I was a kid, I used to have a bit of asthma when I was a child. My mum would just take me to the GP surgery, no appointment. You just sat there for an hour and you were seen. And he'd give you an inhaler and you went off and everything was fine. The other thing I had was eczema, because, you know, the asthma and eczema are both allergic to. I'm growing out of them now, and I'd go and have some steroid cream from the GP. You had easy access to your doctor. Now it's actually very difficult to get an in-person doctor's appointment, and all sorts of systems are in place to stop that. And you have to understand those systems, because if you want to go through and succeed, you have to break through them. So the other thing is hospitals. You know, hospitals in the most general hospitals have about 500 beds, and they have an emergency room and maternity care, and they have a variety of other specialties. Some have cancer, some have endocrinology units where thyroid disease is treated, others don't, and they refer on to another hospital, maybe part of the same group. One of the trends we've seen in Britain over the last decade is that hospitals are going bankrupt. No one goes bankrupt in the public sector, but they essentially run out of money. And the way to sort that out is to fuse them with another hospital, usually a bigger hospital. So Banbury Hospital goes out of business. It doesn't shut, it just joins Oxford hospitals. High Wycombe Hospital, which is the nearest one to me, doesn't do well financially, so it joins Stoke Mandeville Hospital, and they become big trusts, and they end up fusing the hospitals. And one of the problems with the public sector is that you're a customer, but you're not considered as a customer. You're considered as a service user. And that's the weakness in the public system. You're a service user. There's nowhere else you can go. However competent the staff are, there's some very competent people in these hospitals that will treat you, but you have no choice about where you go. You can't sort of go around it. You have difficult access. You know, the only example of perfect technology in the NHS is actually the vaccination program for COVID. That was just perfect. Very expensive. One can question whether it was really necessary. But the NHS app that I've got on my phone is unknown before. There was nothing like it before, and there's nothing like it again. Why can't I book with the same app a GP appointment? I can't. When you ask, why can't I book a GP appointment? Well, everyone will be booking GP appointments. Well, that's the thing. Why not? That's what people want. They don't want to have to phone a receptionist every time they want something. And the other good thing about the NHS app is you can get repeat prescriptions. So if you have thyroid disease, I'm sure you get it online, and you go to the chemist down the road and collect it the day later. And it's very, very efficient. But the rest of it, the delivery system is cumbersome. And it's the same in many countries. And it's as though, if you compare it with a budget airline, for example, which is cheap and cheerful, but very good links to you as a customer, Ryanair, EasyJet, even I can book a ticket without any education on the computer program. I can do it very easily. It's sort of a natural process. With the NHS technology, it's very difficult to do a lot of things. I think that's the problem we have. Delivery in hospitals, the 500 bed, and if we go around the nearest hospital, which is Stoke Mandeville to me, which has 500 beds exactly, and I was on the board of it for 3 years, so I know it quite well. And you go around there, 500 people are in there tonight. It's costing about £780 a night for someone to, sort of 24-hour period for someone to be in that hospital. Obviously, intensive care is double that, and there are some low dependency areas for rehabilitation that would be less than that. But on the whole, it's nearly £1,000 a night. And if you go around there, you'll find most of the people over 70, significant number over 80, and many of them, probably 20% at any one time, this is repeated around the country, don't actually need to be in hospital. And why are they there? They're there because there's no one else. There's no one to look after them, and there's nowhere for them to go. They're not poor. They're not, they're not sort of living in poverty somewhere. There's just, they're not well enough, and they have no relatives, or no one's willing to look after them. And so that's part of the problem now. And you hear about these in times of winter crisis, all these ambulances queuing outside hospitals. It's just that you can't get people out, so no one can get in. And it's not a medical problem, it's a societal problem rather than a medical problem. And that's the challenge, how we solve that. And neither Labour nor Conservatives have got any idea how to solve it. And, there's got to be a better way of dealing with it, because it's blocking the whole technology of the medical care system. It's not as bad in other countries in Europe for various complex reasons. First of all, society tends to look after older people better in especially Italian type countries to the south and Mediterranean countries. The older person is revered, and they're looked after if they get ill by the family. The other reason is that there is more capacity within the healthcare system than we have in Britain for a variety of reasons. So my prediction for the future is the delivery of care will become much more outpatient based, just like cancer chemotherapy. We admitted everybody for chemotherapy to hospital, proper bed, admission notes, and all the rest of it. Now no one gets admitted, or almost nobody. They go to a clinic, totally run by nurses, not a doctor in sight, computerized prescriptions for drugs. And that's the way it should be. Daycare surgery is taken over. Most people, for most operations, it's a day or a single overnight stay if it's a more high risk of complications, and they go forward. So technology is changing, and the delivery of that technology is changing. And in thyroid disease, I think the same thing. It's really mainly an outpatient specialty. So people are going along to have their medication adjusted, their diagnosis made in a clinic rather than being admitted for investigations. When I was a young houseman at UCLH, we had people in the beds being admitted for investigation. They just lie there having a series of tests. Sitting in pajamas, it always, when you look back, why are these people in pajamas? Because they're in hospital. But why do they need to be in hospital? They could come back every day for a series of tests. Or even more efficiently, a computer program could select them a day where they could book all the tests sequentially. So they come in at 10 o'clock and they go home at 4 o'clock, having all the scans, all the blood tests they need in one visit. And that's got to be the future for the delivery of care. The third box for the future, which I partly talked about, is societal change and how society values universal healthcare. In other words, not free healthcare, nothing's free, but everybody gets good quality care. How much does society want to value that? Does society want to value old people more or less than young people? And, we always argue about this as doctors. So at Hammersmith, we had a little sort of role play game where we said, we only got 20,000 left in the budget for the rest of the year. We'll give you 5 cases, at least cost 20,000 to treat. You have to order them in your preference. So the one that always wins, because it's the extremes of it are always very easy. What's not so easy is when you're in the middle. And so let me give the extremes. One was an 18-year-old boy with Hodgkin's disease, chemotherapy, 6 cycles, chances of cure 90%. So he was top, obviously. Everybody scored him as top. At the other end, there was an 89-year-old heavy smoker with lung cancer who'd failed 1 cycle of chemotherapy. The disease was growing. Was it worth trying another one for £20,000? And he was at the bottom of the pile. And then in the middle, you had various things. But it's all very subjective. And who decides? That's part of the problem. And how much do you involve the patients in the choice of how you allocate resources like that? So society has difficult decisions to make. And just as I say, in some cultures, and I was with the World Health Organization for a couple of years, and it was great. I mean, I ran the cancer program, so I used to go to interesting places. And cancer is the same all over the world. But in very poor countries, there are no drugs, there are no resources, there are no scanners. And I remember vividly in the Mekong Delta in Thailand, bordering on Laos, there were no oncologists, there was no cancer service. But when you went there, people used their own resources. They used herbal medicines, which killed the pain from the bark of trees. And the family all sat round the person who was dying from cancer and looked after them. And they were usually elderly, and it was, the chickens would run around, the pigs and so on. And everyone was sort of happy. They were in a sort of relationship with each other, the family structure. And that, sadly, in many Western countries, there's many exceptions, but in many Western countries, that's gone. It's just left. And so that was almost like perfection, a place where there's no drugs, herbal pain control medicines, and people are happy as a family structure. So I was really taken by that. So society has to evolve better ways of dealing with it. We're not going to have a pill for every ill. It's a myth. And of course, the whole pharmaceutical industry, which Judith has been part of, is based on that they're going to make money out of selling pills to people. And you've heard recently about the obesity pills. They work, but only temporarily. You really have to have willpower as well as them to make them work. So that's going to be the future. So the 4th box for the future is the most difficult, and that's how we pay for healthcare. And that causes all the political problems. And, our poor old NHS is just a political football to all the parties. It doesn't matter what they are. They all come up with grand plans that are never implemented. The current one, the 40 hospital plan. And Steve Barclay, the health minister, was on the TV the other day squirming when the question of he got an interrogation of what's happened to the promise of 40 new hospitals. And it turns out maybe there's some renovated wings of old hospitals as well. And some of Labour plans are unrealistic. So, I mean, there's only 3 ways to effectively pay for healthcare. Number 1 is tax, and that's what we mainly do in the UK through the NHS. The second is insurance, which is the way Europe works, and both systems are universal, and everyone gets care. Even if you can't afford to pay for your insurance, you'll still get care through a mechanism of social insurance in Holland, in Germany, in France, and so on. So tax, insurance, and then the third way is cash. And what we've seen over the last 2 years, people are going into their own pockets to get private GPs, to get prescriptions, to get private appointments for hip replacements and so on, because they don't want to wait to join the waiting list in the NHS. So these are the really only 3 ways to pay. There is a 4th one, which is charity, which it's interesting. The hospice movement, end of life care, effectively is 50% charity, more than 50% charity. And that works for complex reasons. It's very difficult to have it sustainable. Now, you're a charity, and you know how difficult it is to go fundraising, and it's very challenging out there. And if you had to spend it on treating thyroid disease, you'd soon run out of money. So what you're doing is the most effective way is as an information charity, communication charity, supporting a defined group of patients with thyroid disease. So that does seem the best way of relatively limited resources. If you had to spend it on investigations, you'd soon run out of money. So the politicians argue about how we get the balance between tax, insurance, and cash. And, you know, then you get the ethical dilemma of should you pay for cosmetic surgery out of tax, or should you pay for gender reassignment out of tax? There's all sorts of difficult areas, and ethicists love debating these things, and there's no correct answer. You have to make a decision of how you do it. So let me just, because I'm conscious we've been going for 20 minutes already. I'll just go on all evening if I'm not careful. How you beat the system. You know, the best example that's in the book, one of my friends is an airline pilot for British Airways, and the biggest disaster in British Airways at Manchester Airport in 1985. And a plane was taking off for Corfu at 6:30 in the morning, and it was on the runway, and one of the engines caught fire, and 55 people died in the plane. It was a Boeing 737. And he told me that he was part of the inquiry into the disaster. The airline industry takes even totally minor disasters very seriously, much more seriously than we do in healthcare. And he was actually on the board to introduce British Airways investigation schemes to the NHS, which he did about 10 years ago. But he told me about the air crash. He said, you can see it on the web, you can look it up on Google. You can actually find the official report. And it has a distribution of where people were sitting on the plane and the outcome. So most of the people that died were at the back of the plane. As I say, 55 people, sorry, a fly just went down my throat, very helpful little fly. 55 people died. Nearly all of them were at the back of the plane. And if you look at the map of the deaths, seat 20B, the patient, the customer sat there and he managed to get out. How did he get out? It puzzled the investigators. The only explanation is that he just went for it. He just pushed through and got out. He's just so driven to do that. Now, you can argue the ethics of this, but in any constrained system, those that are pushier in a polite way, politely persistent, are likely to get more help than those that are just quiescent and just sit there and wait. And that's part of the problem. And to do that, to be pushy in healthcare, you know, the 6:30 in the morning and the plane's on fire, it's your personal, just your will to survive and so on. You just jump through to get out. In healthcare, it's different. It's understanding the system, making sure that what you're asking for is what you actually need. There's no point asking for a drug that you can't get and fighting for it and going to court to try and get it if it in reality is not going to benefit you. So you need that information. And it always surprises me, so few people that have cancer have in possession two documents. One is the report of the exact type of cancer, the biopsy report that's come from taking a sample of that cancer. And the second thing is an imaging report from the scan, CT or MRI scan, to show where the cancer is. These are the two key things that decide all treatment. And it always surprises me that people don't know that this is important. Quite often I'm asked by friends to say, oh, look, Mrs. Smith, my friend, Mrs. Mormay, my uncle's got cancer. Can you help? I said, well, I can't, but I know what type of cancer it is. It's no good. We need to know the exact type, the biopsy report, and we need the imaging report. Without that, you just get second or third hand information and it's all wrong. So it's the same for any disease, the same for thyroid disease. An informed patient is an empowered patient. So actually having the information about your disease and what you think. What I was I was asked a question by Louise that was sent in by one of your members who can't be here today. And it was a very subtle question. I was a bit worried you're going to grill me after this on exactly this level of questioning about T3 and T4 and the availability and the risk of getting cancer for those people on T3 and T4 supplements, thyroxine and levothyronine. And I looked at the website and the campaign to get T3 available orally when it became incredibly expensive and ridiculously expensive because it's a cheap drug to produce. It was just, there was a monopoly producer and they just charged the price up. And I was really impressed with the, this is a great example where information and patient power created changes, and it went up to the House of Lords and so on. But you had to have that information. Without the information, it couldn't have gone anywhere. And it's the same for cancer patients. They need information. And just to finish off, I'll end up by talking about rationing, because rationing is everywhere, and it doesn't matter where you are. It could be in New York, fully insured, gold-plated insurance, American insurance in a fancy New York hospital, or you could be in the Orkney Islands in Scotland, sitting in the local cottage hospital up there with some illness. Rationing is in place, and you have to just recognize it is there, and there's nothing you can do about it, but you have to work around it, and you have to think like the man in seat 20B in the Boeing jet that was on fire. You need to get out of this, and we call it the fire. Everybody in health hospital administration knows about rationing. We don't talk about it much because it's not polite conversation to say we're giving ration care, but everyone does it, and there are the 5 Ds of rationing. The first is denial. Doesn't exist. We don't do that here. No, you read it in the Sunday Times. They write a lot of rubbish in the Sunday Times. It's, there's total denial. That's number one. That's very powerful in all health economies. The second is delay. And the best example is you've got a dreadful cough and your sore throat, it's really painful, and you can't get an appointment with your GP. So you phone up NHS 11, they tell you to go to a pharmacy. They can't prescribe them, maybe they will be able to soon prescribe you antibiotics, but they give you some expensive throat lozenges and so on, and you feel a bit better, but it's still there and it's banging away. So then you persist with the 111. You're told make an appointment to your GP to get antibiotics. You do that, and then you end up 2 weeks' time, you've got an appointment, but by then you're better. So the GP doesn't have to see you, so you cancel the appointment. So that's the effect of delay. If you were able to have appointments, hundreds of people would go and see their GP if they could see them tomorrow, but they can't. So that's a rationing of delay. Deflection is the third D. Deflecting, saying, oh, you go there, go somewhere else, or you need to change, you need to get a form from your GP. There are all sorts of mechanisms in all healthcare systems that use deflection. Discrimination, there is age discrimination in the NHS still. Certain things are given until certain ages and then you don't get them. And there's no racial discrimination, but there's gender discrimination, but some of it for reasonable reasons, but others sort of a bit bizarre. And then finally, the most powerful one is determination by committee. And in cancer, we have multidisciplinary teams. Endocrinologists work in multidisciplinary teams. So they have a committee that make decisions, especially about expensive drugs, expensive radiation, and so on. And if you're turned down by it, there's no appeal. There's no, the doctor just says, well, the committee won't let you have that. They won't let you have T3, for example. You've got to have T4. That's the committee has said that. And you can hide behind that. So again, an informed patient calmly and pleasantly can start arguing about that decision and try and get it reversed. I think the last thing I'll say about all healthcare systems, you have to understand who's important in the system for what it is you want to get. It's not necessarily as obvious as it seems. So, medicine is very hierarchical. The consultant's thought to be at the top and the healthcare assistant at the bottom with the unqualified, not necessarily even a GCSE to their name. So you think the person you've got to convince that you need something is the consultant, but that's not always the case. The people at the bottom of the pyramid are often more important in small things like getting an appointment to see the consultant, getting your spouse to go along with you to help you argue for what it is you want. The people at the bottom of the pyramid make these decisions. I had a patient at Hammersmith that always got a 9 o'clock appointment on a Monday morning to see me. And she's a long-term patient. And I couldn't work out why. And so I asked my secretary, why is Mrs. So-and-so always coming at 9 o'clock? Because I'm fairly punctual. So she'd be away by 9:15 with a routine cancer follow-up appointment. And she was happy. She'd go to work and so on. I said, oh, yeah, she gives me flowers now and again. I said, what do you mean? Why did she give me a bottle of wine? Not you flowers. I'm seeing her at 9 o'clock. She said, no, it doesn't work like that. I'm in charge of the clinic and who comes when. And she's right. She was. I wasn't paying attention to when people were coming. So I think that's one of the problems, that people think they've got to go to the top to get things done. It's not the case. The people all the way along are really important, and most are competent and most will be helpful. What they don't like are people getting abusive and annoying. And I've seen people swear at the receptionist using 4-letter words in the clinic and so on, and that really, people losing it is not good. And it's polite persistence. If you to get an appointment, to get a scan, to get the result. The NHS is very bad at giving out results. In other words, someone has a scan that's really critical to them. Has the cancer recurred in my speciality? And it can take weeks for the scan to be reported. So there's got to be a better way of getting information back, which, even if it's bad news, it's better to know that what's going to happen next rather than live in this state of uncertainty. So I think, just to finish, I think, all systems have problems, all systems are rations, but information is the key to working out how to make the system work for you. And above all, being pleasant to the staff at all levels, even if things are not going well, even if the clinic's busy and it's hot and you're made to wait and so on, just keep being pleasant, grit your teeth a bit and be pleasant. And things tend to get better if you're pleasant to people. And they don't get better if you get grumpy, and especially if you get aggressive. So there are parallels between any type of illness. The great thing about most patients with thyroid disease, they don't have, on the whole, a life-threatening illness. They're going to survive, like Judith. And thyroid cancers are very well, for most types of thyroid cancer, are very successfully treated today. So, so I'm happy to take any questions. Thank you very much, Louise, for inviting me.
Oh, no, thank you, Karol. That was brilliant. A lot of information to take on there, and very interesting to hear, I suppose, like an insider's view, really. There are a couple of questions on the chat that I'll just put to you. One of them is, will AI overcome the doctor knows best attitude?
That's a great one. I'll tell you what I'll do. I'll ask it when we've finished, and I'll email you the answer, and you can email that. But I'll ask ChatGPT if the doctor. That's a very good question. Yeah. Not only. At the moment it's primitive, it doesn't have a voice, ChatGPT, but it could have it. You could put a voice, and you could select female, male doctor, young, old doctor. You could select what you want. You could even have an image of someone that's doing the talk to you. We can have your image, Louise, and and full of empathy. That would be good. And I don't think there's anything to be frightened of at all. I think all the newspapers are writing frightening stories about artificial intelligence. I think it's information. That's the great thing, and it should be neutral. Can it be taken over by politicians to make you think that you're? That's one of the things. The other thing that could happen is hearing a lot about deep fake things, where we have Louise there and you're saying ridiculous things, but it sounds like you and it looks like you, and it's very difficult to know what's real and what's not real. And that sort of unreality state's more frightening, I think. But I think a lot of NHS 111, I was chair of the East London 111 for 3 years, so I know how that works. And it's a very good system. But highly computerized. The people have had a week's training that do the talking to you on it. They're competent, they can add up, and they understand how to do the system. But the power of it is the computer algorithm there. I did it for an afternoon. I mean, I was under supervision, and the computer is very safe. So if a child has a headache, it goes into a very safe mode. And if the headache, any possible symptoms of meningitis, it automatically calls the ambulance control at Waterloo, and ambulance 999 calls put in, and you can't override it. It just does that. So that's the beginnings of it, I guess. Can you replace the 111 operator with AI? Probably so. That's probably the case, because it's just a mathematical algorithm that's very safe. Would people like it if they knew they were talking to a robot? We're getting more used to talking to robots now. I mean, you know, car insurance, all this, that you don't know who you're talking to.
I was going to say, my house is always Alexa. Be going off somewhere.
Yeah.
Right, we've got more. I think that was a good answer. Thank you.
But I will look it up afterwards and send it you for fun. So.
Okay, yeah, no, I can share that then with the community.
Okay.
We've got a question here in relation to thyroid cancer, where it says fatigue seems prevalent after a thyroidectomy. Is this your experience? If so, what is the cause? Interested, as often hormone levels are deemed normal by professionals, but symptoms persistent.
Yeah, it's very puzzling, and it happens with all endocrine problems, whether it's the adrenal gland, or the pituitary gland itself, or thyroid. And we don't know why. It's probably that, you know, with the thyroid, we measure T3, T4, and that's it. And TSH, the stimulating hormone. But there are almost other factors that we don't understand. And tiredness is very curious. What causes tiredness? It's partly up in the brain, you feel tired. But it's partly a combination of other things, including your appetite, the hormones that come out of the stomach lining, and so on. And they're much less explored than, you know, thyroxine, and the thyroid gland is an old endocrine organ, old in the sense it was discovered a long time ago, and we understand it much more. But I think the tiredness is just very complex, and nobody knows why it is. And I think what will happen with the technology for the future is that we will get better at predicting the exact hormone makeup that's needed to be supplemented very quickly after surgery. And surgery for thyrotoxicosis, for example, you know, you remove the thyroid and everything crashes. You use carbimazole to try, or other drugs like it, to try and stabilize everything. But there's no doubt that there are factors we just don't understand that are related to the tiredness.
Excellent, thank you. The next question relates to what you mentioned about being persistent. Someone's asking that, does being persistent actually hinder your care?
You know, first of all, if it's done politely, no, I think it doesn't hinder your care. And I think at the end of the day, all health professionals want to help. I mean, that they're in that business for that reason. So, you know, if I received a letter as a consultant from a patient, you know, not necessarily an aggressive, unpleasant letter, but a letter saying, look, I've been told I was getting a follow-up appointment. I haven't had one. What should I do? You know, I would immediately say immediate follow-up appointment, because people get worried. And I think the trouble is we tend to trust the system too much. The system, like all systems, have failure. They have things, appointments don't get sent out. If you've been told you'll get a scan in 3 months' time and you don't go back for this, no appointment comes, you can pick up the phone. The trouble is, phoning hospitals is a difficult business. It's not easy. It's not like phoning, you know, places that want your business. You know, it's as though you're just a nuisance. And often the phone just rings and rings and no one answers it. But polite, persistent, you just carry on until you get a response, basically.
Okay. We've got a question here actually from Judith that says, if you're sitting opposite your doctor and they have just given you a diagnosis, be it cancer or thyroid disease, how can you react to get the best information and outcome for yourself?
That's really a good question. I mean, what you can do once you've been told you've got an illness, the thing to do is you need to get more information about your specific illness. So you want, and now doctors, you know, this is something that's happened over the last 20 years. You'll get a copy of the letter. Make sure you get a copy of the letter your consultant or the registrar writes to your GP. That's got all the information in it, or should have all the information in. The other thing is to ask for, if there's been a biopsy, ask for a copy of the biopsy report. And you can also ask for the key imaging report. Now, what's fascinating is some healthcare staff think this, you shouldn't have access to this. When I was a medical student, the hospital notes had not to be handled by patients, as though there was some sort of secret that the professionals had your notes and you couldn't have. Those days are over. Patients can have copies of their notes, but there are some staff that try and play a game. So, oh no, you can't have that biopsy report. I think polite persistence, if necessary, right to the consent, you'd like a copy of your report. It is your body, after all, it's information about you. You're the most important. That information more important to you than to the doctor, in a sense, so or to the nurse or to the receptionist. So you're entitled to that. So I think just being persistent and saying, I really like that. I think also it then allows you to go and look things up on Google and wherever. And the internet has transformed information. There's no doubt. I think we'd all agree that you can instantly find out things in a way that you couldn't do by going to a library. It would take forever.
Yeah, it's very interesting you say that, actually, because that's one of the things that when I talk to our thyroid patients is about getting copies of their own blood results. So they have an understanding of when they feel good, their results are, and that optimal level, and get that understanding for themselves, so then they can have those conversations with their doctors.
I think you're right. And something like thyroid disease, either up or down, or hormones, a graph can help. You can maintain your own graph if the hospital doesn't have one. And we're very bad in hospital visits all across the world at giving a graph for patients. The only exception is diabetes, which is really good because patients self-manage their diabetes. They understand it, and they have a little box. They can do their blood sugars at home, and they can follow this up. And that's going to be the future. A lot of blood tests, you have a little box, and it's done in the box. The signal's transmitted to your computer, then to a hospital central file, and you can see the graph going up and down. And the patient's as much part of the treatment program as the hospital.
Excellent. Okay. One of the other questions is, where does ChatGPT get information from? Do you know?
It's always a year out of date, so you can't ask it. So you can't ask it what happened to what can we take as a topical thing that's happened recently. Why isn't Liz Truss Prime Minister, for example, anymore? It wouldn't be able to answer that because it hasn't got data on that. But if you ask why, or is Donald Trump being convicted of a crime in America, it couldn't do that. So it gets its information from a synthesis of all sorts of things. I'm making this up because I've really, there is no idea where it gets it. To be honest, but at least I'm honest. It's,
well, that's it. It's not.
I'm going to. That's the second question I'm going to ask ChatGPT.
Yeah.
Where do you get it from?
Yeah, that would be useful to know, because again, we can always respond, because that's Kathleen's question to us, was where that gets its information from. So we don't know is the answer to that.
No, we don't know.
Yeah, just a comment. Becky said, she was the lady on the call that mentioned about the fatigue and her thyroid cancer. She just wanted to say thank you. She has been persistent, but she's what was she? I've lost it now. It's moved on. But it only works if there's an understanding of the issue among professionals. Otherwise, no amount of persistence seems to help. So I don't know if you've got any tips on how you can influence the professionals' experience, how we can engage them more in terms of exposing them to those experiences, because we were sort of talking about that last night on a call, about the fact that, for example, in thyroid disease, a doctor may never in their professional career come up against someone that is having persistent symptoms on, say, for example, levothyroxine. Because if, say, 85% of patients respond well and are, don't have persistent symptoms, but the percentage of patients remaining that do and are struggling, they may not have had any professional experience about, in dealing with that. So it's how you can expose, how we as a charity can maybe get access to exposing professionals to those patients. So
I think one of the ways you could do it is organizing a study day for professionals, nurses and physicians, from a patient's viewpoint. And that may be something you could think of doing. It'd probably have to be in London if you want to get the most, and, you know, to give them CPD points and so on, so there's an incentive to come. I mean, it's interesting. In cancer, often people get anemic. They get very low blood counts, and experiencing anemia. I went to an exhibition. It was a cancer symposium, and they had in the exhibition area, they had a lorry parked, and in the lorry it was a virtual reality, what people felt like when they were anemic, which I thought was quite amazing. You put this headset on and you opened the door, and it was like a little sitting room inside the lorry, and it was geared almost like a ride in Orlando, the rides, but you felt really you couldn't move, because that's exactly how patients felt. So it was a very powerful message to those. The doorbell went and you just couldn't get up to get to it in time because you were too weak to do it. So you felt that because of the headset and the gravity effects of the special chair you were sitting in. So can you train people to be more, to understand better how thyroid patients feel when they go through thyroid crisis, or they do a change in the hormones? It all can be done. It's just getting people to do it, I guess.
Okay, that's definitely something I know it's definitely on our,
one
of the many items on our agenda.
You'll be busy. You'll be busy.
That's it. Yes, we are. Just think we've got one final question. I'm just going to make make sure I haven't missed anybody. Here we go. This may not be one that you can answer. It says that I've had an annual appointment with my thyroid consultant this afternoon and was asked about whether the keto diet is okay for thyroid patient conditions.
No. Nobody knows.
Nobody knows.
I mean, if you worry about overweight, the keto diet's no magic. None of these diets are magic. It's like fasting's not magic, and it's prolonged fasting, or 2 days fasting and 3 days eating, or 4 days. My arithmetic's about 5 days eating and 2 days fasting. It's a simple equation. It's like a water container, and what goes in and what goes out determines how high the water is. If more goes in than goes out, you're going to get big. If more goes out than goes in, you'll be fine. It will be thin. And you know, the problem with low thyroid is, unless it's adjusted properly, you do get quite heavy. Just in the same way, thyrotoxic patients often become very thin with it, and everyone's different in how they respond.
Yeah, absolutely. Well, I think that's it for questions. So, see, I did say to you, didn't think you'd have many as tricky as the one we sent you the other day. So hopefully that wasn't too taxing for you. But thank you very much indeed.
Pleasure. And Judith, bye. Nice to see you.
Yeah, okay. And thank you very much to everybody for joining us this evening. I hope you enjoy the rest of your evening, and that there's sunshine where you are.
Yeah.
Enjoy your garden, Karol.
Thank you very much. Thank you very much.
Take care.
Bye. Yes, have a good evening.
Bye. Thank you, Judith. Thank you.